Corey, very much. Good morning, everybody. So I am here to talk about adjuvant therapy in non-small cell. Is there any hope beyond chemotherapy? Now, why in the world would we need anything beyond chemotherapy? Chemotherapy is awesome, right? Well, maybe not so much in this case. And how am I advancing these things? Green, yeah, impression. Okay, there we go. No, that was, hold on a second. Okay, so actually, adjuvant chemotherapy for non-small cell is something that's relatively recent, and that's because there were several studies using old-school alkylating agents that showed no survival benefit. But when you put the platinum-based chemotherapies, the older studies, in a group of the randomized studies, there was a teensy-tiny benefit seen for those patients who got chemotherapy with platinum-based agents after their surgery for lung cancer, and it was about a 5% benefit at 5 years. So it was this study that led to the YALT study that was designed to confirm that. And patients who had surgically resected non-small cell were randomly assigned, my clock's not running, by the way, randomly assigned to old school platinum-based chemotherapy or observation. And while the study initially was felt to be positive at the even more minuscule benefit of 4.1% at 5 years, with further follow-up, it actually lost its statistical significance. So what happens is that the curve bows right around 5 years, and you've got more people alive than dead at 5 years, but then the curves come together, as all curves eventually do, but this one did so sooner than we would like to see. And that's because patients who got chemotherapy were better off in the period of time when they would have been dying of their lung cancer, but once you get past that and it's clear that you're cured of your lung cancer, you're actually worse off if you'd gotten chemotherapy. And those patients had an increased risk of death if they had actually gotten chemotherapy. So that was not the most impressive initial foray for platinum-based chemotherapy. Then this study, NCIBR10, came along, and that was a smaller study, only 482 patients, who got a more modern chemotherapy regimen, a cisplatin vinorelbine, versus no chemotherapy, and patients were stage 1B or 2. And this actually showed a more impressive benefit at 5 years, 15% when initially reported. With further follow-up, this also is not as impressive. The 5-year survival is down to 11%, but it has maintained separation of the curve. So the benefit does persist for those patients who were treated with this regimen. The more modern platinum-based adjuvant studies were put together in the LACE meta-analysis, which looked at 5 platinum-based studies and looked at those patients, not exactly the patients we see now. 80% of them were male. The elderly, as often, were underrepresented. Only 9% were over 70 years of age. Stage 1A patients were also underrepresented. Only 8% of patients had stage 1A disease. More patients than we usually see had a pneumonectomy, about a third. And the histology matches what we kind of used to see and not so much what we see now with the plurality of patients having squamous cell carcinoma. Nevertheless, this meta-analysis did show, once again, that we have a smidgen of a benefit for platinum-based chemotherapy. If we're looking just at lung cancer death rates, your risk of death from lung cancer goes down by 6.9% if you get adjuvant platinum-based chemotherapy. But chemotherapy is not the most fun thing, and it does increase other risks, and your risk of non-lung cancer-related death actually went up 1.4% if you had gotten adjuvant chemotherapy. Here's the forest plot of those studies that were included in the LACE meta-analysis, showing that the hazard ratio for overall survival was not the most impressive of 0.89. But remember, these are patients who are being cured of their disease who otherwise wouldn't be. Progression-free survival was also statistically better when you combined all these studies. These are the current NCCN guidelines telling you who you should treat and who you shouldn't treat. So for resected patients, stage 1A, it is recommended that those patients be observed. For stage 1B through 3A, those patients, for stage 2 through 3A, those patients should get adjuvant chemotherapy. For stage 1B, it's a little less clear. You can either choose to observe or you can choose to give chemotherapy for high-risk patients. That's 1B and also 2A, node negative 2A. Those were actually 1B patients at the time that all these adjuvant studies were done. Why are those the recommendations? And if we look at the LACE meta-analysis, we can see that for the stage 1A patients, again, I told you they were underrepresented, but they actually had a worse survival if they got chemotherapy than if they had not, with a hazard ratio of 1.41. So patients with 1A disease are likely to do worse. Stage 2 and stage 3 have a clear statistical benefit with chemotherapy, but the 1Bs cross the 1 mark. So they didn't clearly do worse, but they didn't clearly do better either. But if we look at these individual studies and try to figure out why is that? Can we tease out those patients with 1B disease who might do better? One of those high-risk features that dropped out was a tumor size greater than 4 centimeters. And if you look at those two studies that were able to do this analysis, the BR10 study and a CLGB study, which was a study of adjuvant carboplatin and Taxol, those patients with tumors over 4 centimeters did do better if they got adjuvant chemotherapy, while those who had tumors less than 4 centimeters did not. Of course, 4 centimeters is not the break point in the old staging system, nor is it in the new staging system. So that's where we stand on chemotherapy. How about going beyond? Well, one of the drugs that has been looked at is bevacizumab, which has a survival benefit in the metastatic setting, albeit a modest benefit, but it is approved in that setting. So ECOG 1505 took bevacizumab into the adjuvant setting. Patients with resected non-small cell lung cancer, stage 1B greater than or equal to 4 centimeters through 3A, were randomly assigned to get 4 cycles of cisplatin-based chemotherapy, or 4 cycles of chemotherapy plus bevacizumab given with the chemotherapy and then continued for a total of a year. Investigators could choose any of a number of chemotherapy regimens: cisplatin vinorelbine, which was the most commonly used in the LACE meta-analysis, cisplatin docetaxel, cisgem, or cispemetrexed for those patients who did not have squamous histology. The bevacizumab dose was what we usually use in lung cancer, 15 mg per kg. So this study was unfortunately a negative study. There was not a benefit for the addition of bevacizumab in either overall survival or progression-free survival. So this is not going to change our standard of care. We are not to give our patients bevacizumab. If this study also allowed looking at the various regimens that were used, and there were actually no differences in overall outcome in terms of survival for those patients getting any of the itemized regimens that were allowed to be included. There was, however, a difference in toxicity, I think, as anyone who treats these patients knows. There was more febrile neutropenia seen in the patients who got the vinorelbine-based regimens. There was more thrombocytopenia in those patients who got the gemcitabine-based regimens. The regimen associated with the least total grade 3 to 5 toxicities was the pemetrexed-based regimen, which of course was only allowed in those patients who are non-squamous. Now moving on to EGFR TKIs, these have really revolutionized our treatment of the metastatic patients who have EGFR mutations, and these have been looked at in the adjuvant setting. The initial study was the BR19 study, which looked at the initial EGFR TKI that we had, gefitinib. Patients with stage 1B through 3A non-small cell lung cancer who were resected were randomly assigned to gefitinib or placebo, where they got the gefitinib, the oral TKI, for 2 years. This study was designed before adjuvant chemotherapy was standard of care, so it had to be modified in 2004 to allow for adjuvant chemotherapy. And unfortunately, this was a negative study, both in disease-free survival and overall survival. The patients who received gefitinib did not do better. In fact, if anything, the trend was for them to have done worse. So this has not changed our standard of care either. But these were all comers. What if we just look at the EGFR mutations? And they did do an analysis of this study in those patients. And the results didn't look that good in that group either. They did not seem to have a better PFS or overall survival if they had gotten gefitinib. But I want to point out, there's only 15 patients. It was a very small number of patients who were found to have EGFR mutations in this group. And maybe gefitinib isn't the drug we shouldn't have been using in the first place. If we look at patients who had predominantly wild-type EGFR in the second and third line setting, the BR21 study had shown that there was a modest survival benefit to Erlotinib, but that was not seen in the ISIL study with gefitinib. So that's part of the justification for the Radiant trial, which is another study of an adjuvant EGFR TKI. These, again, were patients with stage 1B through 3A non-small cell lung cancer, and they were allowed to get chemotherapy if indicated, 945 patients. This was not all comers. This was meant to be an enriched population who were likely to benefit potentially more from EGFR TKIs. They had to be either FISH or immunohistochemistry positive for the epidermal growth factor receptor, not a mutation population, but positive by FISH or IHC. And they were randomly assigned to Erlotinib for 2 years or placebo for 2 years. And RATS, what we have is another negative trial. The primary endpoint was disease-free survival, and in the group overall, that was not beneficial for the Erlotinib group. It was, however, beneficial for the patients in the EGFR mutation group. We had a much bigger number of patients in this group, over 150 who had EGFR mutations, and they had a dramatically improved progression-free survival or disease-free survival relative to those patients who only got placebo. 55% of the patients had deletion 19 mutations, and 44% had L858R. And here are the overall survival results. Now, these were immature. Only 28% of patients had died at the time that this analysis was done. No benefit in terms of overall survival at all seen in the intent to treat group, and no apparent benefit in the mutation-positive group, but again, emphasizing that this is an immature result. So there are the studies that have looked at adjuvant TKI specifically in the EGFR mutation patient population. This is the SELECT trial, which was a phase 2 study of adjuvant Erlotinib in patients with resected non-small cell with EGFR mutations, and they were allowed to receive chemotherapy, 100 patients. This was reported at ASCO in 2014 on the 100 patients who were well balanced between the stages. Staying on adjuvant oral TKIs is difficult, and 40% of patients did require a dose reduction from the standard dose of 150 down to 100. There were 24 recurrences, but only 2 happened while they were on drug, 22 after stopping. The median time to recurrence was 12 months after stopping the drug. 63% of patients underwent a repeat biopsy. Only 1 was found to have the resistance T790 mutation. 17 of the patients who recurred were retreated with Erlotinib, and at the time of this presentation, 10 of them had remained on Erlotinib, and only 8 patients had died. And this is the disease-free survival, which was pretty impressive, 89% at 2 years for this patient population. There is a Chinese study that was looking at adjuvant gefitinib, but it was a small randomized phase 2. So these were patients with N2 positive non-small cell lung cancer with exon 19 or 21, exon 19 deletions or 21 point mutations, 60 patients. They all underwent carboplatin and pemetrexed as adjuvant chemotherapy, and then were randomly assigned to gefitinib for only 6 months versus observation. And for those patients, we did see a markedly improved, once again, disease-free survival for those patients who were treated with the adjuvant gefitinib. Overall survival also trended positive for those patients who received adjuvant gefitinib, did not reach statistical significance. Remember, this was a small randomized phase 2 study, but the hazard ratio was very impressive at 0.37. So maybe EGFR TKIs are a good idea in the mutation patient population, but we have not yet established an overall survival benefit. And this is one of the questions being asked by the very large Alchemist study that we are participating in. This stands for, and they're pushing these acronyms, Adjuvant Lung Cancer Enrichment Marker Identification and Sequencing Trial. Patients who undergo resection of their lung cancers have molecular testing done to figure out whether they have ALK or EGFR mutations. They get chemotherapy as indicated by their stage of cancer, and then those who are found to have EGFR or ALK mutations undergo randomizations between 2 years of their targeted directed therapy, either Erlotinib for the EGFR mutants or crizotinib for the ALK rearrangements versus placebo. So hopefully this will give us the answer as to whether or not this is something we should be doing routinely for our patients. There is even something in the study for the non-mutated patients, and that is nivolumab for those patients who are not found to have mutations. So speaking of nivolumab, that brings us now to immunotherapy. So one of the largest adjuvant studies done was a vaccine-based study called the MAGE-A3 study. It was a phase 3 study, over 2,000 patients who had resected with their lung cancers. They were randomly assigned to a vaccine called the MAGE-A3 vaccine versus a placebo. They could have gotten chemotherapy or not. MAGE-A3 is the melanoma antigen family A. It's tumor-specific, and it's expressed on lung as well as other malignancies. It's been shown to be associated with a poor prognosis. And it was shown to be promising in a randomized phase 2. It looked like there was a benefit to patients who had gotten the adjuvant MAGE vaccine. But unfortunately, the phase 3 study was negative. So this is yet another attempt to build on chemotherapy that has not changed our standard of care. So this is a Japanese study of chemoimmunotherapy. These were patients with high-risk resected disease. 1B through stage 4 were allowed. They had to be less than 76 years of age. 100 patients were randomly assigned to 4 cycles of platinum-based chemotherapy alone or with autologous activated killer T cells and dendritic cells that were given for 2 years. Now, this trial actually falls into the category of almost too good to be true. There was a dramatically improved overall survival as well as progression-free survival for these patients treated with the T-cell therapy. Again, small study, needs confirmation. The side effects are what one would expect with this type of therapy. Chills, shivering, and fever were experienced by those patients getting the immunotherapy. What about checkpoint inhibitors? Right here is the survival curve for the first-line study of pembrolizumab versus chemotherapy in high-expressing PD-L1 metastatic patients, showing us that checkpoint inhibitors are looking very promising in patients with non-small cell lung cancer. And that is what the ANVIL study is looking at. The ANVIL study is the subpart of the Alchemist study that is looking specifically at those patients who are not found to have EGFR mutations. So patients are registered to the Alchemist via screening. They're found to be EGFR and ALK wild type. They're stratified by stage and histology as well as PD-L1 status. And the stratification for whether or not they're PD-L1 positive uses a PD-L1 marker of 1%. Remember, the study that just showed the benefit of first-line pembrolizumab, which we'll be hearing about, had to have patients be 50% positive for PD-L1. But patients are randomly assigned to either a standard of care after chemotherapy of observation or nivolumab for 2 weeks up to a year. And not to be outdone, there is also an adjuvant pembrolizumab study, the PEARL study, which somehow is pembrolizumab, lung, adjuvant. I'm not quite sure exactly how they get PEARLs. But patients for this study are surgically resected. They undergo their adjuvant chemotherapy, and then they are randomly assigned to undergo pembrolizumab for a year or placebo for a year. The primary endpoint to this study is disease-free survival. Secondary endpoints, overall survival, and lung cancer-specific survival. Now, we just heard about SBRT and radiation for early stage lung cancer. Well, how about postoperative radiation therapy? You know, chemotherapy may not be our only hope. This has not been considered a standard of care for the most part, and in large part because of the PORT meta-analysis, which came out in 1998, which actually showed that patients who got postoperative radiation did worse than those patients who did not. This was following their surgical resection. However, if you just look at those patients with N2 disease, they did not do worse, at least. They struck even. They did about the same whether or not they got postoperative radiation therapy, whereas those who had node-negative disease or stage 1 or 2 disease did much worse with radiation therapy, suggesting that those with the least to gain have the most to lose. And there are lots of criticisms of this meta-analysis. The staging was variable and unspecified. There was not a specified interval between resection and PORT. Not all the studies that were included were even published. There was short follow-up. Why would you ever give postoperative radiation to node-negative patients? Mitch McTay actually did a retrospective review of patients who were treated with more modern radiation therapy after surgery and showed that actually it didn't look like they were killing people with postoperative radiation. The actuarial rate of death for intercurrent disease was what one would expect for these patients. So there have been some analyses, retrospective analyses of patients getting postoperative radiation therapy in more modern times. This is an analysis of the ANITA study. This is one of the platinum-based adjuvant randomized studies. And in this study, investigators could choose to give postoperative radiation if they did so consistently, and 33% of the patients on the observation arm versus 22% on the chemo arm did get postoperative radiation therapy. For the group as a whole, chemotherapy was the best approach following surgery, but then better than getting nothing was getting either radiation or the combination of chemotherapy and radiation. Within the N2 node-positive patients, however, the best outcome were for those patients who got chemotherapy and radiation. They did better than the chemotherapy alone, did better than those who got radiation alone, and did better than those who got nothing. So their survival was, median survival was 47 months if they'd gotten both versus 24 months if they had not gotten radiation therapy. And here are the survival curves for those patients, showing that the top line are those patients who got both chemotherapy and radiation. There has also been a SEER analysis of N2 patients, whether or not they got postoperative radiation with a statistical benefit to postoperative radiation. And there's been a more recent analysis of the National Cancer Database that was published in JCO that also showed that the patients who got postoperative radiation therapy fared better in both an adjusted group and an unadjusted group if they got postoperative radiation. So, of course, those are all retrospective analyses and don't really answer the question. So there is the LungArt study, which is a randomized study trying to answer this question: is postoperative radiation therapy for N2 positive patients really beneficial? So now getting down to my conclusions. Adjuvant chemotherapy. 4 cycles of platinum-based chemotherapy following surgery for stage 2, 3A, and selected 3Bs is the standard of care. The only defensible thing right now to do beyond chemotherapy is post-op radiation if the margins are positive, which is sort of obvious, or if there's N2 disease. Stay tuned for data on targeted and immunotherapies that are going to come out of the Alchemist and the Pearls trial, and please refer patients to clinical trials so we can see if we can get better treatments than just chemotherapy. Thank you.